अभी वो तो बन रहा है उसका। So, good afternoon, everybody. And today we are going to talk about a very, very interesting case in the grand round section of a case of monogenic obesity. Now, obesity is something which we see right day in and out, but most cases do not have a genetic etiology. In fact, most of them don't even have an underlying pathological cause. But there are certain disorders in which you can have a lot of genetic component, and that can have significant implications in terms of diagnosis and management. So, we'll be illustrating index case which will really highlight about the complexities of assessment and how difficult it may be in terms of evaluation and management from that perspective. So I'll just start off with this initial case which we saw some time ago. This is a 3-year-old girl with rapid weight gain, and what we found in this scenario was that there was height was 84, but the weight was quite significantly elevated to 26 kilograms. There was severe hyperphagia since birth, and this is something which we need to understand, that if you have an early onset syndromic features, especially hyperphagia, that becomes a significant scenario we have to look at. So this was an early onset obesity in which what we are seeing is that there is hyperphagia which was there. Basic workup was all normal. Everything was normal. There was no developmental issue, vision, infections. And normally we say that if a child has a normal growth, puberty, development and eyes, we consider it to be an exogenous or constitutional obesity. But if its onset is too early, we have to think of a possibility, and this child was found to be a leptin deficiency in that regards. Identification of this will have implications in terms of treatment options availability, in terms of pubertal issues, in terms of immunodeficiency issues, which may happen subsequently in that regards. So obesity overall is quite common in the population, around 10 to 15%. 98% of it is exogenous, and genetic causes is definitely less than 1%. Even if we talk about selected individuals in the first 5-year or first 2-year bracket, the prevalence is less. So before 3 years of age with hyperphagia, still 5 to 10% will have genetic cause. So it's not an exceedingly common cause, but if you identify, you have a lot of implications which we need to evaluate and other perspective. Syndromic obesity, of course, is an important chunk. We are not going to discuss about syndromic obesity. We are talking about single gene disorders which do not typically cause any dysmorphism in most scenarios, and it has implications on treatment and prognosis, which we'll discuss about from that regards. All of you can go and have a look at our website, learning.rosociety.in, wherein we have got a lot of e-learning portal, including our YouTube channel, our website, which has got a lot of tools related to pediatric endocrinology, including fellowship and postgraduate courses. We do run grand rounds, PG lecture series, and journal clubs frequently, and our publications are there, and the mobile application which can guide on. Latest of it is our obesity interpreter, which will be quite relevant from this perspective, which allows when to think of a genetic cause, and that's been accepted for publication in pediatrics, should be coming soon. So I'll hand over to Dr. Alappan, who will talk about the interesting case, and we will keep the discussion rolling from that regards.
Thank you, sir. Good afternoon, everyone. So I'll start with my case. A 6-month-old girl child presented with increased weight gain, which was noticed by her parents since birth. There was associated excessive hunger, which was also present since birth. Now the history of present.
When you say excessive weight gain, how do you define excessive weight gain in this period?
Sir, during the during the neonatal phase, there is initial there is a weight loss of around 10%. Then after at 10 to 14 days of life, the child gradually tends to gain weight, and around up to 3 months they gain weight around 20-30.
So what is more? When you say excessive weight gain, what is the definition of excessive weight?
We should calculate on the basis of weight for height for this child, whether the weight for height is more than 2 standard deviation score according to the WHO standard.
So
Correct.
weight for length will be the criteria to look at, but historically, some rough ball figure. So how much you said they gain in the initial month? How many grams per day? 30 grams per day. So overall, if you say that we expect the birth weight to double by around 5 months. So if you have some crude idea that, okay, within 3 months, the weight has doubled. Often this happens in these sort of cases, you will expect that to be there in that perspective. And excessive hunger, that's a very, very difficult symptom to get it. So how did you get the question?
The parents told that even if the child was fed, the child was initially 5 months for the breastfeeding. Even if the child was fed, she was crying, irritable, demanding, and whenever they are feeding the child, again she become sleeping or something. And so,
and the other thing to look at is how frequent is it? Like after that, how long is the child stable? So normally at around 3 months of age, we expect the feedings to be around 3 hourly or at least 3 to 4 hourly in that regards, maybe 6 to 8 feeds a day. But here, if you're having hour, that becomes very, very significant. What else could be indication of hyperphagia at this age? One is demand, continuous cry, not getting full. So if mother's milk is inadequate, despite good production, if the milk is inadequate and they have to resort to formula feeding, that also can be significant, because these are two remarkable symptoms that you are saying. You're saying about excessive weight gain and increased appetite. So that becomes very, very significant from the clinical perspective to decide about from that perspective.
And in that case, sir, also the weight gain will not be there. Matlab, if mother's milk is not
adequate, so they are forced to give top feed.
Okay, then that
will be the scenario to look at in that regards. What is the most common cause of excessive weight gain in the first 6 months?
Ideally, the inadequate calorie intake due to the calorie dense milk intake.
So breastfed babies are more likely to gain more weight, or the formula fed?
Formula fed will be
formula fed are, but there are also clear-cut growth trajectories which suggest that breastfed babies can also gain a lot of weight. And then at 6 months, suddenly the weight gain becomes less. So we are not excessively aggressive in the first 6 months unless it's very, very significant. Carry on.
So the parents complained about increased weight gain since birth, which was getting more rapid for the last 3 months. There was excessive hunger as discussed. The child is demanding, crying, irritable for breastfeeding every hour almost, and even after feeding sometimes he is not sleeping properly. So coming to the history of present illness, there is no history of any feeding difficulty in feeding, any delayed motor milestones, weak cry or failure to thrive in the early phase. There is no history of any visual abnormality as child is looking to her parents are smiling, on all the developments are almost normal.
So you have mentioned very nicely about Prader-Willi syndrome. Do you think this is the age at which the weight gain happens in Prader-Willi syndrome?
No. No, sir.
So that is making it less likely. But hypotonia definitely is part of many other syndromes as well, as you mentioned. That becomes important.
There was no presence of any extra finger in the hands or feet of this child. There was no history of any poor feeding, difficulty during sucking, poor weight gain, sweating during feeding, visual disturbance, and hearing defect present in this child. There is no history of, though not that significant, but no history of any respiratory distress or any hard kind of bony swelling that is present below the skin in this child.
Why respiratory distress?
Some of the case reports of PHP I have seen they presented in the neonatal period with hypotonia and respiratory failure leading to ventilation. So that's why I mentioned it.
Because of?
Hypotonia, because of the
pseudo-hypoparathyroidism.
Okay. So that's why I mentioned it here. There is no history of any recurrent diarrhea or hypoglycemic episodes
So
present in
if you
our.
want to look at PHP in the child,
Hmm.
it may not be very easy to identify cutaneous calcification because at this age it may not have developed.
Hmm.
So which parent would you like to examine?
Mother.
Yes. So
Hmm.
even clinically the mother.
Hmm.
You can often get the mother has brachymetacarpia, short stature, moon faces, round faces, and cutaneous calcification which can be there. In fact, I had a mother who gave a history that they had removed lumps which were calcium. These history can become relevant.
Moving on to the history of past illness and the treatment history.
So now any other, so this you have largely tried to exclude the causes which are syndrome.
Hmm.
Are there any other causes that you're worried about?
Drug intake would be one that would
Yes.
be important in this age group.
What else?
Apart
So what are the most, in other words, I'm trying to say that what are the common causes that you're thinking of at this moment?
at this moment, the monogenic causes of obesity and the syndromic causes would be the first priority.
Then
Drug-induced Cushing could be one, drug-induced and also endogenous Cushing.
okay, anything else?
PHP will not present like this one.
Something which is causing hyperphagia.
So, inadequately treated NDI.
Inadequately treated
But
NDI
they are
will cause
giving
failure
much
to
more,
thrive.
giving much more top fit and gaining rapid weight gain in that
So
setting.
very rarely some form of diabetes insipidus where you are giving lot of formula feed rather than giving water, they can become obese. But anything more common, more important. Anybody who has hyperphagia and obesity, where is the satiety controlled by?
Hypothalamic lesions or any kind
Yes.
of it.
So that will be a very big thing that you have to always worry about. So the main cause of worry would be, okay, you have no syndromic features, whether it is a lesion. That becomes very, very important if you have that. And then you think of a genetic cause from that perspective. Can hypothyroidism present like this?
This kind of significant weight gain will not be present in hypothyroidism.
Okay.
And there will be developmental delays present, obviously.
So you might have to add features of any seizures because otherwise it will be difficult to mention blanking like episodes which can be there. So these will be suggestive of an intracranial one. Then you can ask history of polyuria because that's a surrogate marker of DI, but which may often not be there. But dehydration, polyuria, you should at least document that there is nothing in that regards because I have seen one patient with diabetes insipidus. But that was a 1.5-year-old child who was being fed a lot of formula feed because of his thirst. And that led to obesity in that regard. So that is the scenario. And Cushing syndrome is quite rare, causing that much obesity so early on. If it is Cushing, what are the cause? Such early onset Cushing's?
It should be adrenal carcinoma or something.
Most commonly, adrenal carcinoma is the cause here. Carry on.
There is no past illness of significant illness or NICU, PICU admission. There is no current treatment for weight gain that child is currently receiving. Moving on to the family history, there is no family history of obesity in the family or no history of any consanguinity between parents. The development is according to the age for this child. She sits with support within tripod position and speaks the monosyllable words at the age of 6 months. Moving on to the antenatal history according to parents were uneventful. There is no history of any polyhydramnios or less fetal movement. There is the history was
what does less fetal movement in a child with obesity indicate?
The child was a term child with a birth weight of 3.1 kg and no history of any intensive care admission. There is no drug history, as I've already mentioned.
You talked about lack of hypoglycemia in the neonatal period. What are you looking at?
I have taken the history for the PCSK1 deficiency.
Anything else? Any other? Not maybe obesity, difficult to say obesity, but in which the body size is more causing hypoglycemia.
Beckwith Wellman would be one possibility.
That will be an important cause to look at. Overgrowth syndromes.
Yes.
Yeah.
Appetite is increased in this case. Coming to the nutritional history, the child was exclusively breastfed for the last 5 months, followed by complementary feeding and currently on home-based semi-solid diet. The nutritional intake is mostly due to the excessive hunger and there is an attraction to the calorie dense food in the last follow-up that we get, that sweet things the child prefer more in terms of food preference. So based on my history, the 6-month-old girl child with normal vision, hearing, development, and no history of any drug. So the probable etiology, and we have to mention about this, there is no history of any seizure or any intracranial pathology, any eye signs. The probable etiology being monogenic.
Possibility would be a hypothalamic
Obesity is also there. Yes.
So what is the cause of hypothalamic obesity? What is the biochemical hallmark of hypothalamic obesity?
How it happens?
Yeah.
So hypothalamus basically controls our satiety actually. There are two pathways there. One is...
So what is affected? I'm asking specifically for that one biochemical pathway or the one pathway which is mainly, how do they behave? If you want to compare them to a monogenic obesity, which form of monogenic obesity will they resemble? So when they, what acts on the hypothalamus?
Leptin acts on the hypothalamus.
So
leptin
they behave like a leptin resistance. So basically hypothalamic obesity is like a leptin resistance equivalent from that perspective.
So on the general examination, the child is alert, conscious, and playful. Faces I have described about is round faces, depressed nasal breeze is there, and there was downward bending of the angle of the mouth present in this child. Vitals are normal. The skin of the child is a fair complexion child, and hair.
Now, fair complexion, you have to be more objective about that compared to the parents.
Compared to the parents, actually, sir.
The child is more fair, or is it because of the diagnosis that you thought of?
Sir, the child is a bit fair complexion in comparison to at least his father, at least. I have not seen her mother actually.
But the main issue would be that whether it's too significant finding or it is in retrospect. That
I think it's the one retrospective findings actually, sir.
Because I think this is something which we need to clarify that often once you know the diagnosis, then you start looking at things. But maybe on the first clue, we did not find anything because that's important that clinical clues may not be there in these cases.
Here there is no red and depigmented hair.
Why did you look for that?
To rule out the POMC defect in this child. And there was no finger abnormality present in this child.
And what is the pattern of POMC defect in terms of hair color? Does it vary with ethnicity?
It can, sir. It depends on the amount of pheomelanin and eumelanin concentration actually. So based from the red hair to brown hair to completely pigmented hair, the full spectrum can be present actually.
So it depends upon the ethnicity. So for most of the Indian people, you may not even find because the pigmentation is good enough anyways. It will be more relevant from the European or Caucasian, where this red hair thing is reported more. So it's interesting that many of the POMC defects, if they are reported from outside those countries, they have a normal in that regard. So that does not exclude
POMC.
The possibility of a POMC defect. Of course, we'll talk about that a bit later.
Yes. Decimal staging is prepivotal in this child. Anthropometry, you can see the weight is +4 standard deviation score at the 6 months of age, and weight for length is +3.5 standard deviation score for this child. I have given a chart how the height and weight has progressed for the last 5 months in our child actually. And
but this is not progressed too much. If you look at it in the last 5 months, only gained around 2 kgs.
2 kgs, yes.
While earlier she was 12 kgs. So there was a much more pronounced weight gain in the first 6 months, then it becomes settled. So what do you think would be the cause?
Because I think from our OPD visit to up to 11 months, he was given a diet which will be less calorie dense, low glycemic index foods are given, and child has been properly monitored whether his weight is gaining properly or not.
So this is quite good that if you look at the weight gain in that 5-month period is not dramatic. Otherwise the trajectory was quite high.
Yes, sir.
And what's the fourth one is head circumference?
Yeah, the red one is.
The red one.
Red one is.
And that bottom one?
That is the weight for length, sir.
Weight for length. What does it mean?
Weight for length, sir.
So weight for length has to come as a SDS or a percent. It doesn't come like it's not weight for divided by length. Okay, carry on. So as you said, this thing.
So actually, I just wanted to show you the weight for length was quite similar. Matlab the height
Stable.
gain and weight gain was almost similar. That's why
Yeah.
it was not been changed that
So
much.
if we had the SDS, it will be a better.
Better, yes, sir. Yes. So if we see the weight for age for this child, we can see there is a weight gain, but not that significant, as sir has already mentioned about that. And if you see the weight for length, again, it is more than 97 percentile, but it is taking a upward trajectory here. So systemic examination in this child was absolutely normal. So we moved on to the investigation, and we found that all other investigations, routine investigations for this child was normal, except the thyroid function, in which there was low FT4 level associated with a mildly elevated TSH level in this
So
child.
what do you think, Nimisha, here? So do you think central hypothyroidism can explain the obesity?
Not alone central hypothyroidism.
So it has to be part of some picture.
Hmm.
Let's assume the FT4 was normal and your TSH was 8 or 9. What are you thinking of? Which condition will come to your mind? In a child who has obesity and increased appetite, mildly elevated TSH with normal FT. Yes, so this will be a TSH resistance. So you may also have the more common finding in pseudo hypoparathyroidism in infancy is high TSH than low calcium. Hypocalcemia is often delayed in that perspective. So that is something, but here you have a very, very low level of FT4 that you are seeing. So of course you will like to confirm it once before you go ahead, but this is quite low from that perspective. And the cortisol level?
Initial point, we didn't do that. We just go on the next we got an impression whether it is a central hypothyroidism or not, and we moved on to the repeat test of FT4 and TSH, and this time also it is a similar kind of result, a low FT4 with a mildly elevated TSH level with a normal cortisol level, ATM cortisol level.
And what does IGF-1 tell you?
So it was done from outside.
IGF-1 will have no role here. What are the fallacies of IGF-1 at this age?
It is a nutritional based marker. It is not after 5 years.
So less than 2 years, no role of IGF-1. And why are we looking at IGF-1? When you're saying it is like a central hypothyroidism, you're not thinking of growth hormone deficiency at this age anyhow. And so that's a very, it's not going to help you also.
Can that's thinking of ki it could be a part of multiple pituitary hormone deficiency can lead to IGF-1. That was
IGF-1 is not a good test to do in somebody who at this age. So it is not going to be of help.
So from here, our differential diagnosis are differentiated into two parts. One is the isolated pituitary hypothalamic disorders like hypothalamic tumors or congenital pituitarism versus the syndromic or monogenic obesity with central hypothyroidism that is often seen in cases of Prader-Willi syndrome, Bardet-Biedl syndrome, Alström syndrome, and the leptin melanocortical pathway defect like POMC, PCSK1, or leptin receptor defect.
So why does leptin defect cause the central hypothyroidism like you?
So leptin has a role that we know that TSH is mainly regulated by hypothalamic TRH from the paraventricular nucleus. This is the direct pathway from where TSH is regulated. But there is an indirect pathway where leptin also controls this. Leptin directly stimulates TRH, and also leptin in the indirect pathway via NPY agouti-related peptide and POMC pathway. They also indirectly control the TRH.
What is more common link between leptin and TSH?
Because when the energy levels are high, when the leptin levels are high, we want to burn more energy. That's why TRH is stimulated, and that is why.
So obesity is a classical example of that borderline TSH. This is because of a high leptin. But if you have a leptin resistance, why is the TSH still high? You're seeing your TSH is high.
Probably the leptin is working on the different pathway, so indirect pathway, and then that is
so leptin is causing the central hypothyroidism. Maybe the abnormal form of TSH being produced. Whatever TSH is there is not
so bioinactive TSH.
So it is central hypothyroidism. It is because leptin is not working. So what it means is that it is not only related to leptin, but it is a distal effect of leptin, because you are saying it's happening in till around POMC PCSK1. Does it happen with MC4 receptor defect?
Not common, sir. Not
So
seen
it is
that.
probably proximal
Proximal to
to
the
MC4 receptor. So if you look at leptin,
Hmm.
leptin acts on POMC, then PCSK converts into that, and then it's going to act on the MSH, MC4 receptor, and then you have the BDNF TRK pathway, which we'll
yes.
talk about a bit later.
Hmm.
Yep.
So there are two differential. So we have two plans in our hand right now. For the obesity purpose, we want to
And
look.
one big possibility is rather than having MPFD, you can say this is a sort of a big non-functional lesion or some other lesion, not just a hypothalamic, but not just the hypothalamic pituitary, but some other lesion which is causing central hypothyroidism, and the lesion is causing hyperphagia.
Yes, sir. So for the organic pathology, we planned for the MRI brain to look for any organic pathology in the brain. And for the monogenic obesity, we suspecting monogenic obesity, we are looking for the clinical exome sequencing in this child. So this provisional diagnosis of 6-month-old female child with normal vision, hearing, development, and no history of drug intake, probably etiology being monogenic obesity or hypothalamic obesity with central hypothyroidism. Moving on to the definitive diagnosis, the MRI brain has been done and it is showing a small size pituitary gland, but the rest of the pituitary gland is normal, though no tumor or anything that compresses the pituitary is present or hypothalamic region is present. The posterior bright spot is well seen in this case.
So size may be a difficult scenario to
Yes.
go ahead. Can you explain smaller size in this case? Is there a way in which, or maybe you once you know the diagnosis, you can come back?
Size was small because the pathway is not one.
So, what are the major contributors to pituitary size?
The genes.
Cells.
Growth hormone, somatotropes, somatomammotrops.
Somatolactotrops are the most common then.
As TSH and thyrotrops. Corticotrops is there, but less amount.
So theoretically, if the stimulus is less, you can have smaller pituitary, but I would not give too much importance to that. It's maybe milder variation.
Yes. So we go on to the genetic report for this child, and the genetic report this time had shown a defect in the POMC gene, which was associated with adrenal insufficiency, early onset obesity, and red hair in children.
So POMC stands for?
Melanocortin.
So what all is being produced by POMC?
There are 4 hormones that is produced, 3 hormones mainly produced. One is MSH that has 3 parts, alpha, beta, and gamma. ACTH is produced from the POMC, and beta endorphins are produced from the.
So what you expect if the POMC is not there?
If POMC is not there, the MSH part, alpha MSH especially, acts on the MC1R receptor that causes the pigmentation part, the hair, skin, the pigmentation part is controlled by that. MC2R receptor, ACTH acts on that, produces cortisol in our body. And MC3 and MC4 both helps in the satiety and overall energy regulation in our body. So if it is not present, so chances of obesity, increased hyperphagia, that are more common in these cases.
And endorphins?
And endorphins are for the pain regulation. Whenever there is pain, endorphin causes decrease in the pain sensation in our body.
So are they known to be more pain increase or decrease? What will happen if there is a problem in POMC?
So that should be hyperalgia. Pain should be increased actually.
So
pain should be increased, sir. Yes.
In which condition you have got decreased pain sensitivity with obesity?
Prader-Willi. So the definitive diagnosis right now, 6 months old child with normal vision, hearing, development with no history of drug intake, etiology being monogenic obesity due to POMC deficiency. But when we explain this case, there are 2 major questions that came in our mind, that why, if it is associated with cortisol deficiency, why the cortisol deficiency is not present in our case. Even the child is right now 11 months age and still cortisol's level are like 350 nanomole per liter. And second part, why central hypothyroidism develop in this case. So as it has been already discussed, that PO melanocortin has several parts, ACTH, alpha MSH, and beta endorphins, and it acts on the MC1, 2, 3, 4 receptor respectively. So this is the triad of POMC deficiency. We have already discussed about it: the adrenal insufficiency, red hair and fair skin, and the early onset obesity due to MC3, MC4 receptor defect. This case has been published in 2021, which has explained about 2 cases of POMC deficiency along with the previous cases of POMC deficiency that has been present in the systematic literature review. They have shown an interesting chart where they told that obesity and adrenal insufficiency among those 22 children were there total. Among those 22 children, the obesity and adrenal insufficiency are present in 100% of the cases. There are few cases of central hypothyroidism is present, almost around 40% cases of. There are few cases of type 1 diabetes, hypogonadism, and growth hormone deficiencies also associated in cases of POMC deficiency. So I'll move one by one. First, the obesity part. We all are aware of this pathway. We all know that in hypothalamus, there are 2 significant pathways. One is a orexigenic pathway, that is appetite stimulating, and another is the anorexic pathway, that is the POMC CART pathway. So in this case, the POMC CART pathway is not there. So there is excessive hunger, and that leads to increased excessive calorie intake, leading to obesity in our child. Moving on to the next part, that why there is no cortisol deficiency in this case, the probable explanation is in some case reports, there has been shown that if it is a heterozygous mutation and it is a dose dependent effect, how much the gene inactive that is present, they may not have extreme obesity, red hair, or sometimes have some normal cortisol secretion. But they have also warned about that the cortisol deficiency may be evolving, and sometimes it may present as late at 9 years of age. That has been case reported.
Who have lower cortisol levels, primary or secondary adrenal insufficiency?
Sir, the lower levels are in the primary.
Why?
Because there are some ACTH independent actions also.
So that is also important. So ACTH is doing what? It's just pushing star inside to increase the production. But maybe even if you have got limited amount of ACTH amount, that may be sufficient to for the adrenals to produce the cortisol as well. So it may happen during stress, during other illnesses, and that may become important. But as you said, it may evolve also over time. So isolated ACTH deficiency, if you look at it, hardly any cases we see of. So what are the causes of isolated ACTH deficiency? Generally, we always look at in terms of GH deficiency. Then only the manifestation becomes important of hypoglycemia. Isolated is known as, in which cases have isolated?
TPIT is one that causes, POMC can cause
the other defect. So, but they are very, very rare scenarios. They don't usually present with adrenal. They present with other features.
So as our case was also heterozygous, probably we are expecting that, but we have to keep our eyes open regarding the subsequent development of the adrenal insufficiency, as it is very common in this case.
Do you agree with their classification of uncertain significance?
No, probably it has not, the mutation has not been reported yet. That's why it has told uncertain significance. But if you see the pretest probability in this case, this is a complete case of.
This is pretty good that you have got obesity, early onset hyperphagia, central hypothyroidism. So POMC is a strong possibility.
So the central hypothyroidism part has been already described, and it has been multiple case reports and multiple articles are there why central hypothyroidism occurs in not only the POMC but also the total leptin melanocortin pathway that has been explained. So there are effects of leptin on the directly on the paraventricular nucleus and indirectly by arcuate nucleus, the agouti related peptide and the MSH pathway.
So ultimately, as you nicely said, if your energy levels are high, you want to burn some calories. That's why TSH is going to be high. If your leptin is low, you want to become hypothyroid. So if you look at all the malnutrition related cases where leptin is low, you have features suggestive of central hypothyroidism. That sort of a scenario can also happen in that regard. T4 is low, TSH is not elevated. So that sort of a scenario can happen.
Thank you for this.
Thanks a lot, Alapan, for covering this part. You will come back when you talk about treatment subsequently as well. So just a quick recapitulation of what Alapan has already said, that that it's the medial basal hypothalamus which is the main regulator of appetite. And here we have got the two key pathways which are there. We have got the central processing unit, which comprises three major nuclei: the ventromedial hypothalamus, the arcuate nuclei, and the nucleus tractus solitarius. There are the anorexic pathway, which basically tells us we have eaten a lot and spend more energy through the POMC card pathway, and the orexogenic pathway, which say that we need to eat more and don't want to spend a lot of calorie through the AGRP, neuropeptide Y pathway. The major signals that are coming through them include the mechanistic signals which come from the stomach via the vagus. So if the stomach is empty, you will get a signal that you want to eat. There would also be a signal of ghrelin which will tell the food should come. Then of course we have got the nutrient signals which are going to control that. The major nutrient signals of course include the GLP, which we talk a lot about in terms of pharmacology, insulin, and then we have a major player of leptin, which is regulating a lot of process, and leptin can be considered as a status symbol of what our nutritional or energy status effectively is. And of course from there we have got the efferent pathway which regulates the sympathetic activity from that regards. The leptin, POMC, MSH, MC4, BDNF pathway is central to the whole process. So it's all part of the chain. And if you remember this, most of the genetic etiologies, the monogenic causes will come up from that in that regards. So we have got leptin, which acts on the POMC neurons to produce POMC, which is then cleaved via the proconvertase and carboxypeptidase into MSH. Of course, you also have ACTH coming into that, endorphin coming to that, and MSH acts via the MC3, MC4 receptor in the paraventricular nuclei and lateral hypothalamus to then subsequently stimulate the brain-derived neurotropic factor BDNF in the ventromedial hypothalamus, which again uses a TRKB receptor to cause decreased appetite and increase energy expenditure. So the overall anorexic pathway is asking us to eat less and spend more. You need to have everything in check. So if there is a problem in leptin, problem in POMC, POMC activation, MSH receptors, BDNF or TRK, you will have a monogenic obesity. Now, most of these, except for BDNF, do not have any significant syndromic features. So that's why we talk about syndromic versus non-syndromic from that perspective. So monogenic syndromes can be part of the leptin POMC pathway, problems in the MSH receptor, MC3, MC4 receptor particularly, and the BDNF pathway. We'll be focusing predominantly into these, which are the major cause. The most common cause, of course, is considered to be the MC4 receptor, which is an important cause in that regards. So leptin deficiency was one of the first causes of monogenic obesity which was reported. It is an autosomal recessive condition, first reported in a Pakistani individual in consanguineous family, very early onset of severe obesity, recurrent infections, and there was later on pubertal delay. With leptin treatment, there was a dramatic improvement which was there. The manifestations, of course, are a very severe hyperphagia and food foraging, and because leptin is very important for growth hormone secretion, despite being obese, these individuals are not tall. Everybody who is obese should be tall, but leptin deficiency will be normal height or short in that regards. Because leptin is essential for puberty, they will have delayed puberty. They will also have this plus minus central hypothyroidism like picture, and immunity is also compromised in that regards. So they are normal growth development, or in fact they may be short. So maybe a few which is there in that regard, may also develop infections and steatosis later on. Management, of course, is with metroliptin, which is effective but it's quite expensive and not easily available. It improves hyperphagia and satiety in that regards. Leptin resistance is the default mode in obesity. Now, once leptin was discovered, everybody thought that we can give leptin and there will be a wonderful drug to treat obesity. But what people realized is that most obese individuals are leptin resistant because their leptin levels are high, and because of this resistance, they are basically having these problems. So probably the answer is leptin sensitization, although that's not very easy to achieve. So most obese individuals will be having high level of leptins. So while low level of leptin will be of importance in monogenic obesity, suggesting a leptin deficiency, higher level do not suggest a leptin resistance. You need to go for a genetic test here in that regards. So again, leptin is high, starvation response is there, so there will be hypothyroidism, there will be pubertal delay and short stature. So early onset severe hyperphagia, again all the similar findings as leptin deficiency, the features will be milder because some amount of action is there. Do not measure leptin levels in this scenario, better to go for genetic testing. Management, of course, is difficult, and we'll talk about how all the pathways which are proximal to MC4 receptor, whether it is leptin receptor, whether we have POMC, whether we have a MC4 receptor defect, we may consider setmelanotide, which is the MC4 receptor agonist, which we'll talk about a bit later from that regards. Now, the defect that you're discussing about in this case, which Alapan has already discussed about, is a problem in the pro-opio melanocortin, and it could be both heterozygous and homozygous, deficiencies of ACTH, MSH, and endorphins. Manifestations are early onset hyperphagia, ACTH deficiency, variable pigmentation, and as discussed, hypothyroidism may already be there. And very importantly, because of the important role of MC2 and MC4 in maintaining the blood pressure, autonomic features are also common and they may develop unexplained hypotension, and they are supposed to respond well to MC4 receptor agonist. Proconvertase is a phenocopy of POMC defect. Essentially, you are not able to cleave POMC. So you will have problems in that. In addition, where all you want to cleave the peptide, particularly insulin, particularly AVP, the problem will also be added. So the defect is in impaired splicing. You will have problems in multiple hormones who are produced as pre-pro. So pro-opiomelanocortin, pre-pro AVP, pre-pro GnRH. So all of them cleavage will be difficult in that regards. You will have again similar findings with ACTH deficiency, diabetes insipidus and diarrhea, and hypoglycemia because of high levels of proinsulin, because it's not being able to be broken down from that regards. MC4 receptor, of course, is the site where MSH is acting. It is the most common cause, at least in the Western reports, is the most common cause of monogenic obesity, and they have high level of insulin resistance. And because of that, they are tall. So if you have a very early onset of obesity with tall stature, MC4 receptor is the thing that you're looking at. And they also have a problem in the autonomic functions because the receptor is not working. It is again difficult to treat. In some scenarios, they may respond because if the receptor defect is responsive, you may respond to setmelanotide. Otherwise, bariatric surgery becomes the only option. BDNF is subsequent to the MC4 receptor. So this is one condition where setmelanotide is not going to work. The defect, of course, also has other features of neural involvement. So a number of syndromes are associated with these conditions: hyperphagia, developmental delay, and hyperactivity and learning disability. So to summarize, leptin defect causes early onset hyperphagia, delayed puberty, short stature, immune problem. Treatment is leptin. Leptin receptor, again, milder form treatment could be MC4 receptor agonist, POMC, ACTH deficiency, central hypothyroidism, depigmentation, hypotension, PCSK, multiple endocrine abnormalities, including that of POMC, along with insulin and diabetes insipidus, MC4 receptor, tall stature, insulin resistance, where surgery is recommended, and BDNF is more of a neurological, so it's more like a syndromic cause rather than a monogenic non-syndromic forms of obesity. So when should we think of a genetic obesity? So as I always say, for any genetic cause, you need to have 4S: soon, between below 2 to 5 years of age, severe, segregating, that is the family history or family history of consanguinity, and finally syndromic features like hyperphagia, developmental delay, visual problems, or neurological features. So any of these, think of a genetic obesity. So our approach basically, of course, is to look at the features of growth, puberty, and onset. If everything is normal, it's exogenous. Slow growth suggests endocrine. Early onset less than 5 years, we then go classify based upon the development, dysmorphism in vision, to identify syndromic causes. If they are absent, in that scenario, we probably most likely go towards the genetic analysis. And now probably we should not even do leptin. We can directly go ahead with the NGS because that may be more reliable and easily available from that perspective. So once you have excluded the common endocrine causes, once you have excluded the hypothalamic obesity and syndromic causes, go for NGS. If you're looking for a syndromic cause, then you go for NGS with MLPA to look for Prader-Willi syndrome in that regards. So 3-year-old girl with rapid weight gain, Dr. Alapan, height 84. We've discussed the severe hyperphagia since birth and normal FT4. Everything is normal and no other problems. What will you do here?
The early onset of obesity with severe weight gain is there, and rest of the all investigations are normal and development vision, these are normal. So we need to go for a genetic study.
So we should go for the genetic analysis, and at that time we used to do leptin, but ideally we should go for a genetic test in that regards. 2-year-old girl with weight 24 kgs, rapidly progressive hyperphagia. Would you like to do a genetic diagnosis here, Nimisha?
So we will initially look for any syndromic features.
So there are no syndromic features?
No visual or
no visual problem. So do you think it's merits a syndromic genetic cause evaluation?
We need.
So it is soon 2-year-old. It is severe. It is syndromic hyperphagia. There's no family history, but that's when you need to evaluate, and that echoes with most of the international guidelines like the Endocrine Society and the IAP guidelines about genetic obesity. 4-year-old boy with hyperphagia, height is 114 centimeters, weight is 28, normal development and vision. What are you thinking of?
Age is less than 5 years here. Severity is high because at the age of 4 years.
And height is?
And the height is a bit taller on the side actually for 4 years of child. So early onset obesity with a tall height. Monogenic obesity due to.
So look for acanthosis because they have a lot of insulin resistance. And once you do a further workup, you will be able to find a MC4 receptor defect in that regards. So now what could be the therapeutic options that are there? The options could be if there's leptin deficiency, you can give leptin. Beyond that, whether it's a problem in the leptin receptor, problem in the POMC, proconvertase, or even at the MSH MC4 receptor, you can use MC4 receptor agonist, which is setmelanotide, which is basically a selective form. So it's a G alpha Q selective. Why do you want this? So why do you want selectivity for MSH? So what does MSH do other than pigmentation or let's say appetite control? One thing we talk commonly about people who have problems in POMC or MSH is what is the effect on blood pressure? So if you have a functional form, it will cause hypertension. So setmelanotide is selective one, which is non-hypertensive. That is the biggest advantage, which is there from that regards. And this is going to decrease your appetite. Other options would be if everything else is gone, you can use either lifestyle, metformin, or surgery is the treatment in that perspective. So recombinant leptin, this is the first study from Dr. Faruqi's group. You can see the massive obesity, and after leptin, there was a dramatic fall. So there is an improvement which happens very quickly, and you are seeing that the weight from 95 is going down somewhere around 80. So in 12 months, decreased by around 15 kg. So typically, most obesity therapy, we are talking about 10 to 15 kgs a year. Setmelanotide is a bit more in that perspective. So there was a good response, but it is restricted to deficiency because most non-syndromic, non-genetic causes have leptin resistance. So giving leptin there will not be of much benefit, very importantly. Now, MC4 receptor defect in this condition, this is going to be talked by Alapan more. Also, you can see dramatic effects. So weight change, you can see, is going up to the tune of minus 60 kgs also. So this is huge decrease in terms of the weight in patient 1, patient 2 also 40 kg. So you can see that there is a dramatic improvement in that perspective. So there is a definite potential in POMC, PCK, leptin resistance, and MC4R. There are people who have also considered whether we can consider them for normal individual also, because this is again a drug which is going to induce satiety. But compared to this, we have got now GLP-1 analogs, which are supposed to do better from that perspective. So MC4 receptor agonist, this was a study for setmelanotide in that group. What you are seeing here is that the weight was 130 to begin with, and day 29 there was a 3 kg loss, already 3.4 kg loss which is there. What was interesting here was that even for the controls there was a 3 kg loss. So which means this is a good drug in terms of efficacy, but still it is not very commonly used from that perspective. It is restricted for that because it has got more side effects. It is a centrally acting drug. It causes pigmentation. There's so many other things happening from that regard. So this is something to look at from that regards. So now Dr. Alappan, you can carry forward with regards to the treatment of this particular case. What are the options available?
Thank you, sir. So the treatment options available, one I have discussed already, that the nutritional management we can do, that we are doing right now. Secondly, for the central hypothyroidism part, we are prescribed thyroxine in this child, and the child is taking regularly for the hypothyroidism. But the other option, as the genetic report has in our hand, and right now we can prescribe for the setmelanotide. That is a MC4R receptor agonist that Sarah has already described about it. It is recommended in the NICE guidelines that it should be used around people of more than 6 years of age with genetically confirmed POMC pathway, PCSK1 defect, or leptin receptor defect cases. It shows to increase the weight, BMI, hunger score, quality of life, and it is a subcutaneous injection, and that is usually started on the dose of 0.5 to 1 milligram and can go up to 2.5 to 3 milligram depending on the age. And as Sarah has already described, that this drug doesn't have potential to cause hypertension as seen in the previous group of MC4R receptor agonists. So this case Sarah has already described. It was published in New England Journal of Medicine. 2 patients had been taken, one 21-year-old lady from Germany and another one was 26-year-old lady from France. As you can see, at the age of 18 years, their weight was way above the 97 percentile in this case. But after the starting of the therapy, as in the initial 15 weeks, we can see a significant weight loss of around 25 kg in the first patient and similar in the second one in the first 5 weeks. Also, they have seen for the hunger score in a Likert basis hunger scoring, and they have seen that there is also decrease in the hunger score in this patient, which increases the quality of life in this patient. The dip in around the 15 weeks, the treatment was stopped there somehow. That is why there was again a significant weight gain. So that is a question, that whether after stopping, how long we have to give
replacement.
Yes, we have
So
to
if there's
continue to
deficiency,
lifetime.
they'll always gain weight. So this basically, like when you're using GLP-1, it is not like you are treating deficiency. It's not like giving growth hormone for GHD. It's like giving it for somebody with SGA. You're treating somebody who doesn't have the defect. Here they have a defect. So you can see the dramatic response if you look at this child at 40 weeks, which basically would mainly mean somewhere around 7 months. There's losses around 50 kg.
50 kg, yes.
Which is unheard of. The second case, you're looking again 20 kg in 10 weeks. So which means 2.5 months. So it's like a huge loss. But definitely if you stop it, they're going to gain again. There's no way out.
And moving on to the glucose tolerance part, that initially the insulin resistance, as we can see from the black curve in the left upper initially it was so high, but after using the drug, in the both patients, the insulin resistance has been decreased. There is no significant difference in the blood pressure, systolic blood pressure, diastolic blood pressure, or heart rate, or any autonomic dysfunction in both of the patients. So up to 2021, these things has been published. And the one interesting fact that in the 10th patient, it is an Indian patient, and still I don't know whether they have a retrospective or something. They have found that skin and hair are lighter than the expected in Indian population. So probably, And other like some features of central hypothyroidism are present. Growth hormone deficiency, type 1 diabetes is very common, not very common, but it is present in some cases. And the hypothesis that has been postulated that probably autoimmune mediated type 1 diabetes is present in cases of POMC defect. So we have to look for the other autoimmune association in the future long. So these are the these are the patients. And the last thing, it is not associated with POMC or MC4 defect. This tablet diazoxide choline has been recently approved by FDA for the hyperphagia part of the Prader-Willi syndrome. And as we know that diazoxide choline is basically nothing but a salt form of diazoxide, which also acts on the hypothalamus on the agouti-related peptide pathway to decrease the hyperphagia in Prader-Willi syndrome. So can that it be a potential tool since it is a oral tablet, once a daily tablet, and so can it be, sir, a potential treatment for in the future?
There have been a lot of talks about oxytocin earlier, also inhaled oxytocin as a treatment of choice, but that doesn't seem to have come up. So we'll have to wait and watch how it progresses. Often drugs come and go. Like when leptin came, everybody thought that leptin is going to be the weight loss drug, but it didn't work at all. So let's see how it goes. But yes, if you have precision medicine, like if you are able to get POMC for this patient, it will be dramatic. MC4 receptor agonist setmelanotide will really change in that regards. So thanks a lot, Alapan, for a wonderful discussion and interesting case. So again, the big message is that if you have an early onset obesity in a child, you need to be very careful and consider a genetic possibility and which can open up avenues for treatment. All of you can go and have a look at our books which are available online, including our applications and our courses which are available in our website. So we will now be looking off if there are any particular questions which are there. Dr. Adele is asking, is the high TSH the consequence of obesity or the cause? In this case, the TSH is not appropriately high. It is actually should have been much higher if the FT4 is low. So here it is the POMC defect or the MSH defect or whatever is going to cause the central hypothyroidism like picture. In obesity, it's the other way around. Dr. Adel is saying, why in the workup investigation the cortisol? So the answer is that we were looking for cortisol deficiency. Of course, if somebody has central hypothyroidism, we have to do cortisol. But again, also in somebody who has early onset obesity, POMC is a possibility. So you should always look for cortisol in that regards. Cortisol should be measured in early onset obesity. It becomes important from that perspective. So I think we have tried to cover a lot of important issues. If there are any particular questions, we will be happy to take. Otherwise, thanks all for joining, and we'll have similar sessions in future with regards to the other aspects of obesity.